أبنائي وبناتي الدارسين للجراحة العامة. This is Dr. Baki, Professor of General Surgery from Egypt. هنستكمل مع بعض مراجعة الجول بلادر عن طريق ال MCQ، وده الفيديو رقم 6 والأخير في هذه السلسلة. Regarding the extrahepatic biliary and vascular anatomy, which of the following is true? Cystic artery usually arises from the left hepatic artery. This is untrue because it arises from the right hepatic artery. The common duct courses downwards posterior to the portal vein in the free edge of the lesser omentum. يقصد الcommon bile duct ماشية ورا البورتال vein. This is untrue. Common bile duct lies in front of the portal vein. The right branch of the hepatic artery crosses the main bile duct posteriorly. This is true. This is the true statement. As you can notice here, the right branch of the hepatic artery go posterior to the bile duct, common hepatic duct. وبعد كده يدي cystic artery. Put in mind, in 10% of people, it go in front of the bile duct, okay? But the true statement here is C. This will be untrue. The cystic artery usually crosses the common hepatic duct posteriorly. This is untrue. Cystic artery بيطلع من right hepatic artery في callow triangle عشان يروح عند neck of the gallbladder. Okay? Put in mind very important concept about the critical view of safety you have to obtain during operation on gallbladder cholecystectomy, whether open or laparoscopic. You have to identify two tubular structure going to the gallbladder, which is the cystic artery and the cystic duct. In old textbook, they identify callow triangle by three borders: inferior border of the liver, cystic duct, and common hepatic duct. Inside this triangle, you will find the right hepatic artery and cystic artery. This is an old textbook. In up-to-date, which is the most respected, updated American source, they define callow triangle by 3C. Callow triangle starts with C, and every border start with C. Cystic artery, cystic duct, common hepatic duct. Cystic artery, cystic duct, common hepatic duct. This is callow triangle in up-to-date. Okay? And this is the critical view of safety. If you cannot obtain this critical view of safety during surgery, you have to do cholangiography, intraoperative cholangiography. If you cannot do intraoperative cholangiography, convert to open surgery. Okay? The borders of the triangle of callow هو هنا هيديك الإجابة على حسب النظام القديم اللي هو إيه بقى. تعال نشوف. cystic duct, cystic artery, inferior edge of the liver. This is wrong. Cystic artery, portal vein and cystic duct. This is wrong. Cystic duct, common hepatic duct and inferior edge of the liver. This C according to the old textbook. This is the borders of the triangle of callow: cystic duct, inferior border of the liver, and common hepatic duct. But according to up-to-date, it is 3C. The triangle of callow consists of upper border cystic artery, lateral border cystic duct, and the medial border common hepatic duct. Okay? Which of the following is a function of the gallbladder? The gallbladder It absorbs, yes, it absorbs water. Acidification of bile, yes. Secretion, yes, it secretes mucus. Storage of bile, of course, all of the above. Okay, go for all of the above. What is the function? Which of the following is a function of bile? Bile, not gallbladder. Absorption of bile salts, absorption of cholesterol, absorption of lipid, yes. Go for absorption of lipid. These two are untrue. Proteins, vitamin B12. Go for absorption of lipid. What is the normal amount of bile produced by the liver daily? You should know it is half to 1 liter. Go for A, 500 to 1000 ml. Okay? A 30-year-old white male with non-hemolytic disorder comes to the surgery clinic with an ultrasound that shows gallstones. What type of gallstones would you expect to find in this patient? Hemolytic disorders, you should look for black pigment stone. Here is cholesterol mixed brown. Yes, go for black pigment stones. Okay, go for D. A patient is post-operative day 2 from lab chole and presents with right upper quadrant pain, fever, and vomiting. Ultrasonography shows biloma. What is the best method of treatment? Intravenous fluid, intravenous antibiotic and bowel rest, or ERCP with stenting of the CBD, or intervention and radiology drainage of biloma, or intravenous antibiotic and drainage of biloma. Once you have such a problem, biloma post-operative, which usually results from slipped clip from the cystic duct, you have to start with B, ERCP and stenting of the CBD, with or without interventional radiology to drain the biloma. But you have to start with B. Okay? How many patients with acute cholangitis present with Charcoal Triad? Go for 50%. Not all patients with acute cholangitis will give you the triad of pain, fever, and jaundice. Put this in mind. Only 50% will give you the complete triad. Okay? What is the most common organism isolated from bile and bile blood culture in patient with acute cholangitis? Go for E. coli. C. Escherichia coli. Okay? Which of the following is considered a complication of cholangitis? Liver abscess, secondary sclerosing cholangitis, portal vein thrombosis, pancreatitis, sepsis, all of the above. Go for all of the above. All of the above. What is the most common type of choledochal cyst? Go for type 1. Which of the following is the most useful for mapping the anatomy of the distal bile duct in the setting of a choledochal cyst? A radionuclide hepatobiliary scan, CT scan, percutaneous transhepatic cholangiogram, BTC, plain abdominal X-ray, ERCP. Go for ERCP. ERCP is the most useful for mapping the anatomy of the bile duct in the setting of choledochal cyst. Okay? Which of the following is a complication of Caroli disease? Renal disorders, recurrent cholecystitis, nephrospongiosis, cholangiocarcinoma, enteric fistula. Go for cholangiocarcinoma. Cholangiocarcinoma is a complication of Caroli disease. 30-year-old white male was recently diagnosed with Caroli disease limited to the right lobe of the liver. The most appropriate management of this disease is, now the disease is limited to the intrahepatic biliary radicals in the right lobe of the liver in the form of congenital cyst dilatation of the wall of the interhepatic biliary canaliculi, go for hepatic lobectomy. Yes, this guy will benefit from hepatic lobectomy. The other sentences are untrue. Resection of the CBD and Roux-en-Y, this is nonsense because the problem is inside the liver, not in the CBD. Internal drainage of the cyst into Roux-en-Y, this is nonsense because you cannot internally drain too many cysts intrahepatic. Resection of extrahepatic biliary duct and hepatoduodenostomy, this is nonsense also. The problem is inside the liver. Choledochal cyst resection, it is nonsense because it is not one cyst, it is multiple intrahepatic cysts. So go for hepatic lobectomy, right? Hepatic lobectomy. What is the most common location of cholangiocarcinoma? Search for C, hepatic duct confluence. This is the most common location of cholangiocarcinoma in this area. Clatyskin tumor. What is the appropriate treatment for cholangiocarcinoma of the hepatic bifurcation? Right hepatic lobectomy, left hepatic lobectomy, Weber operation, bile duct resection, and hepatoduodenostomy plus partial hepatectomy. Yes, go for D, bile duct resection and hepatoduodenostomy plus partial hepatectomy. Okay? How many patients undergoing cholecystectomy are found to have gallbladder carcinoma? Go for 1%. 1% of your patient undergoing cholecystectomy will be found to have gallbladder carcinoma after postoperative histopathological examination. What is the most common gallbladder tumor? Adenocarcinoma, papillary carcinoma, mucinous, squamous cell, oat cell. Go for A, adenocarcinoma. After an uneventful lab chole, 55-year-old white male, the pathology review demonstration of a gallbladder carcinoma invading but not penetrating the muscularis layer. This is T1B. T1A is limited to mucosa, reaching only to the lamina propria. If it goes deeper to the muscular layer, it will be T1B. Okay? I remind you in previous video, we came to agreement that anything beyond T1A, you should go to another trip to the OR. Anything beyond T1A. So long, of course, there is no metastasis or peritoneal implants. Okay? Let us see what is the most appropriate next step in the management of this patient. You did lab chole for a guy and the histopathology came with a surprise. He is harboring gallbladder carcinoma T1B. What you are going to do? No more treatment needed. This is catastrophe because this means the lifespan of your patient, the 5-year, will be in the range of 40%. In block resection of the gallbladder bed, including segments 4 to 5 of the liver and regional lymph node excision, yes, go for this, because it was found that if you make another trip to the OR to resect the gallbladder bed beside segment 4 and 5 and doing lymphadenectomy, this can make the 5-year survival rate for your patient 90% instead of 40%. 40% if you do nothing. If you go again to make this kind of in-block dissection, this 5-year survival will be 90%. Postoperative chemotherapy is ineffective. Biliary stent to prevent future biliary obstruction, this is not an option. Biliary enteric bypass, this is not an option. Go back to the OR again, do in-block resection. of the gallbladder bed, including segment 4 to 5 and regional lymphadenectomy if it is T1B. Okay. 50-old white male underwent lab chole for symptomatic gallstones on postoperative day 4. He complains of pain, nausea. White blood cell 10,000, direct bilirubin is high. What is the most appropriate first study? MRC, abdominal ultrasonography, ERCB, HIDA, percutaneous transhepatic cholangiography, BTC. If you have trouble after doing lab chole in the form of pain, nausea, or disturbed laboratory results, you should start by abdominal ultrasonography. Go for B. Okay. What is the most appropriate treatment for the biliary injury seen? This guy did lab chole and he developed jaundice, postoperative, and pain. They did for him BTC. BTC show this figure. Abrupt cessation of dye at the confluence of the left and right hepatic duct. And you can notice too many clips. This is clip 1, 2, 3. These are clips also about 5. Too many clips in the field of lab chole. This means that was a horrible surgery with a lot of bleeding, a lot of problem. Okay, you did PTC and you have this cessation of the dye at this area. What you are going to do? End-to-end anastomosis of the bile duct. You will get stricture. Roux-en-Y hepatocogenostomy. Yes, you go for B, Roux-en-Y hepatocogenostomy. Okay, the other statements will be untrue. Choledicoduodenostomy, you will benefit nothing. This is far away from the problem. Choledicogynostomy, the same. ERCB and stent placement, not possible. What is possible is Roux-en-Y hepatocogenostomy. Okay, go for B. What is the double duct sign? If you have carcinoma at the head of the pancreas here, it will cause back pressure on the pancreatic duct, and it will cause back pressure on the common bile duct, and both of them will be dilated and can be shown like this. This is called double duct. Double duct is an ominous sign. It indicates carcinoma here at the head of the pancreas, obstructing both main pancreatic duct and common bile duct. Okay, this is the double duct sign. Thank you so much for watching this video. This is Dr. Baki, Professor of General Surgery from Egypt. Now kindly like, share, and subscribe.